So with all this elegant preclinical data, where does this land us clinically? Well, I think it's important to share with you the pivotal mezigdomide dexamethasone study, the so-called MM001 study of mezigdomide and dex, which was then expanded into a large RP2 D cohort of over 100 patients, in which we were able to show in a total of 178 patients, not only consistent activity, an overall response rate of 41%, but remarkable responses in BCMA exposed and/or refractory patients at 50%, and an impressive for an oral agent response rate of 30% in patients with very challenging extramedullary disease. Now, these patients had a median of 6 prior therapies. The majority in the first cohort were triple-class refractory, 100%. And the over 100 patient cohort were triple-class refractory. And very importantly, in the dose expansion cohort, an impressive activity in BCMA-exposed patients. Now, for the focus of today's discussion on management, what we were able to see is that the most important side effect of this class of drugs, and mezigdomide in particular, was neutropenia, but this was readily reversible with growth factor support, dose reduction if needed, and supportive care. Now, with the hematologic side effects being reversible and very manageable, what about the other side effects? Well, we're very pleased to see that the rates of serious infections were low and proved manageable, with the rates of treatment-related mortality very low. In fact, directly related to mezigdomide, this was not seen. But in the context of infections overall, about 3/4 of patients were affected. So this is important to note, but nonetheless, this reflects the classic situation for these heavily pretreated patients. And this was also occurring during the pandemic. So in that context, I think this rate of infection is noteworthy and means it has to be very actively managed. But at the same time, the rates of serious and life-threatening infections, and importantly, infectious mortality, were strikingly low, exemplifying the fact that this was a manageable issue. What's also very important to note is that we did not see COVID mortality in this study, despite this study enrolling at the height of the pandemic. Moreover, we did not see off-target effects that would be otherwise unexpected. Fascinatingly, we did not see neuropathy, for example. We did see some dysgeusia, but this was manageable and very uncommon. And at the same time, we did see some fatigue, but again, manageable and uncommon. Now, in the recent ASH meeting, there was some very nice correlative data seen in terms of pharmacodynamic activity across the doses in our patients treated. And I would just simply make the point that we were able to show reduction in specific tumor burden biomarkers in patients with high-risk cytogenetics and plasmacytomas, reinforcing that there is a real effect from this drug, mezigdomide in particular, in these difficult-to-treat subsets, and in particular in patients with extramedullary disease. Now, when we talk about extramedullary disease, I just want to show you some of the data that we have. This is from patients in the trial. This is actually the visual is of the PET CT of a Canadian patient, and you can see a dramatic response after 3 cycles of mezigdomide in terms of their extramedullary involvement. And the cohort of patients on the left illustrate a group of patients with EMD, and as you can see, very solid response rate was seen at the higher doses of mezigdomide of 1 milligram daily, 3 weeks on and 1 week off. This is particularly striking in this next patient, who's actually a patient of mine, in whom he had a very overwhelming tumor burden of extramedullary disease, as you can see by his PET CT on the right at the time of study entry. And you can see also that by the time he had had 4 months of therapy with mezigdomide and dexamethasone, his response had been remarkable. And we were so gratified by this because this poor gentleman was devastatingly affected by his EMD. His port had closed off with plasmacytoma, for example. And we were able to reaccess his port and to see a dramatic effect from the use of mezigdomide simply as an oral therapy. Now, in terms of real-world experience, has those remarkable data from our pivotal trial been borne out? Well, I'm pleased to share with you that at last year's ASH meeting in December, it appears so. What you can see here is that the overall response rate is a striking 80% in this cohort of patients, and safety, which I think is really important, was similarly relatively reassuring, recognizing that one had the dominance of hematologic toxicity, but again, these infectious complications must not be underestimated. And in this particular study, upper respiratory tract infections occurred in almost half of the patients, which required antibiotic treatment. But most importantly, there were some other rarer infections, but these were patients in whom they were also heavily BCMA exposed, to both antibody-drug conjugates, bispecifics, and CAR-Ts. It was in these patients that we saw the more complex infections such as CMV reactivation and invasive aspergillosis, but this was probably residual from their prior treatments in part, as well as the effects potentially of the dexamethasone and the mezigdomide combination approach. Nonetheless, the fact that they saw response rates I think is remarkable and very consistent with what we saw in our study. I also want to emphasize this is a small number of patients, but nonetheless, it's good to see already real-world data starting to support our pivotal observations in the MM01 trial. Now, in the MM02 trial, where we sought to combine mezigdomide with bortezomib and carfilzomib-based therapies, we were very pleased to see tremendous synergy as reflected in these data. As you can see, when we combine mezigdomide with bortezomib and dexamethasone at the dose of either 1 milligram or 0.6 milligrams, the response rates were close to 90%. In the dose escalation phase, they were a reassuring 75%. And in the carfilzomib cohort, almost 30 patients, they were 62%. Again, a manageable safety profile. Combining the CELMoDs with the monoclonal antibodies daratumumab and nilotinib, again, the response rates from the dara-treated patients were remarkable at 75%, recognizing that these patients could not be CD38 refractory, although 10% of them had had prior CD38 antibody. Differently, the nilotinib cohort, these patients almost all had had CD38 monoclonal antibody and were refractory to it. The response there was nonetheless gratifying at 45%, and the safety profile, again, was very reassuring. At last year's ASH meeting, my colleague, Dr. Clifton Moe, presented our data combining mezigdomide with selinexor and dexamethasone, and again, the side effect profile was most characterized by neutropenia and thrombocytopenia, but off-target effects were not seen, or unexpected toxicities were not seen, and the most common grade 3 or 4 treatment emergent AE was neutropenia that proved manageable in about half the patients. These were a very heavily pretreated cohort of patients, and as you can see, we were very pleased to see excellent results in terms of responses and stabilization of disease. So an overall response rate of 50%, the VGPR rate that was also strikingly high. And the conclusions that Cliff had also, because he had a careful look at the combination of mezigdomide and selinexor in terms of CD8 T cell proliferation and activation, we were very gratified to see remarkable data suggesting that mezi and selinexor upregulates T cell activation and may suppress pro-inflammatory cytokines, which I think is very important as we think about these as strategies integrated with immunotherapy. Now, in that same spirit, when you combine mezigdomide with other exciting small molecules, in this case trametinib and tazemetostat, the results are very exciting. As you can see with tazemetostat, it's a 50% response rate. When it was combined with the bromodomain inhibitor under study, the results were not dissimilar to mezidex, so this particular approach has actually been deprioritized. But combined with trametinib, it was a remarkable 75%. So in that context, really interesting data, and we're looking further to forward more data from expanded cohorts to corroborate that. So as you can see here with the combination of iberdomide and dexamethasone, we saw similar results to start with approximate response rate of around 26% in the over 100 patient cohort D in a heavily pretreated patient population with triple class exposed disease, and remarkably CD38 refractoriness. And then in cohort I, in which we saw a high number of BCMA targeted therapy exposed patients, in fact, all of them, this was a 38 patient cohort. The response rate was encouraging actually at 37%. So we saw a similar thing to what we saw with mezigdomide, where in fact there was an increase in response rate compared to the cohort overall. So this is intriguing, and it suggests this sort of resetting of the immune system by the CELMoDs may be playing a role here in some way, because this was an observation in the iberdomide study and an observation in mezigdomide. Just to remind you, the response rate there overall was 41%. The response in the BCMA refractory patients was 50%. And in this study, iberdomide overall 26%, and then in the cohort who were BCMA refractory, 37%. So a similar sort of construct. And then I think very excitingly, although a relatively small cohort in 18 patients, when you combined iberdomide with bortezomib, you saw a response rate of a sweet 100%. And then what about side effects? Well, I think this is really important to share. No patients discontinued iberdomide due to adverse events, which I think is critical. We saw the same issue of myelosuppression, but again, all manageable. Pneumonia signal was a reassuring 20% or so, and there were no off-target effects, and responses were durable. So I think this is all very exciting. And at ASH recently, there was just this in December, supplement, a quick poster showing that 15 patients undergoing salvage ASCT, and that the use of iberdomide in this setting appeared to be helpful with improved responses and durability of disease control. And just to build on that, if you combine iberdomide with either ixazomib or cyclophosphamide, the response rates are very nice. Basically, you see, particularly in the IBER-SIDEC study, which was a large trial of over 60 patients, you see a very solid response rate of 82%, or almost 50% VGPR or better, a very manageable side effect profile. Interestingly, grade 3 neuropathy was seen in 2 patients in this study, but they had pre-existing neuropathy at time of study entry, which I think is an interesting observation because neuropathy otherwise has not been an issue with either iberdomide or mezigdomide. And when you combine iberdomide with ixazomib dexamethasone, again, the myelosuppression is an issue, but really no additive neurotoxicity. The PN rate here was around 20%, none of which was grade 3/4. So I think in that context, we're seeing a very consistent safety signal from the combination approaches. And when you combine iberdomide with daratumumab, bortezomib, and carfilzomib, again, the response rates improve. It's not as synergistic as mezigdomide, but nonetheless, the side effect profile is also very encouraging and very consistent in this highly refractory population. And then going one step further, what about combining iberdomide with other monoclonal antibodies such as isatuximab, and in this case, daratumumab and carfilzomib? And what you can see in these trials is some very interesting data. I want to bring your attention to the fact that the response rate here is a nice 70% in the combination of isatuximab and iberdomide, and it's a reasonable sized cohort of patients, basically 50 strong. So this is a decent data set that's valuable. And then at the same time, in the Rekindle trial, which was presented in December by Dr. Ola Langren, you can see in this 30-patient cohort that a very refractory population too, as well as prior carfilzomib exposed patients, the response rate was remarkable at 92%, with an MRD rate, recognizing it's a small number of patients, but nonetheless impressive, an MRD rate of 70% in the setting of relapsed refractory disease. And other studies, again, with iberdomide combined with venetoclax, a reasonable cohort here, over 40 patients strong. The response rate was a striking 80%. So again, this consistent synergy being shown. And what I thought was really nice in this study is the adverse events also proved very manageable, with an infection rate of just 20%, which in the context of venetoclax use, I think is particularly noteworthy. So where do the phase 3 studies sit? Well, right now we have Successor 1, Successor 2. Successor 2 is now complete. We had this remarkable early interim analysis result that was announced by press release last week, showing that the primary endpoint had been met, which was great news with such an early look. This was mezigdomide with carfilzomib and dexamethasone against an active control of carfilzomib-based therapy. What's important is that this was over 500 patients strong. Stage 1, stage 2, the primary endpoint was PFS, and very importantly, we're smack on schedule for initial completion and readout. I think what's very critical in this study to appreciate is these were CD38 refractory and LEN refractory patients. This is very important. And I think this constitutes the classic triple class refractory group of patients, and the data from this we're hoping to present relatively soon. But with that primary endpoint being met, data, obviously, we're very excited by that. Successor 1 has rapidly finishing up its accrual. This is mezigdomide, bortezomib, and dexamethasone. It's a larger trial of over 810 patients. And basically, at the moment, with primary endpoint being PFS, we're looking to an initial completion of early next year. Excalibur has met its full accrual and also has met its primary endpoint with MRD negativity improvement as the primary endpoint being together with PFS having already been reported by press release as meeting its endpoint. More data to follow on this when the PFS data are linked to it and will come later this year. But very exciting to see that in these 3 large phase 3s, speaking to Successor 2 and Excalibur, we already have early data to suggest they've met their endpoints. Now, other studies that are ongoing are summarized here. In the interest of time, I won't dwell on them, but just to say there's a comprehensive menu of combinations of mezigdomide with elotuzumab, with additional studies with carfilzomib based in extramedullary disease, and also with set inhibition, and as I mentioned earlier, mezigdomide combined with selinexor. These are ongoing trials. And then with iberdomide, there's some really nice trials exploring iberdomide combined with both ELO and DARA, which I think is very innovative, as well as with ELO alone. And I think these are exciting studies which we'll read out relatively soon. I think particularly attractive is when we start to think about the use of CELMoDs around CAR-T and bispecifics. And in the interest of time, we'll be very quick with this, but suffice to say, there is now a wealth of data supporting the role of the CELMoDs in reversing immune exhaustion and enhancing the efficacy of both T-cell redirection therapy, T-cell engagers in particular, and also CAR-T. And just to summarize here, we've got elra combined with iberdomide, ide-cel combined with iberdomide, arlo-cel combined with mezigdomide or iberdomide, and we have elra combined with mezigdomide as well as elra combined with mezigdomide in another study. So 2 large trials looking at the combination of elra with mezigdomide. So already we have some early data from some of these. The MELT-MM study, which is elra plus mezi, is a combination of elra plus mezigdomide, and basically 75 patients in receiving one of 3 dose levels of mezigdomide have been studied. Or planned, I beg your pardon, and 11 patients have been enrolled at the time of this presentation. And what was clearly seen was an overall response rate of 90%, with over 50% of the patients achieving complete response. And the CRS rate was manageable at 50% with all grade 1. So obviously early data, but very interesting. And then the other trials, of course, are summarized below. But what I think is really interesting with elra and iber is they're in a larger group of patients, about 22 strong so far. They have an overall response rate which mirrors the mezigdomide study, with 91% response rate, 70% VGPR, about 50% CR. So again, this consistent signal of activity. And then I think what's interesting here with the iber study is that the side effect profile appears very manageable. And what you can see here is it's mainly myelosuppression, and basically the rate of infections is around 40%, but very few serious infections. This is then a more comprehensive menu of all the various trials that are ongoing. In the interest of time, I will just simply summarize them to say that mezigdomide has been combined with both ide-cel, talquetamab, teclistamab, ELO, teclistamab, talquetamab, and cevostamab. So, and also ententamig. So all of the major platforms are being evaluated.